green button. And I will let you take it away. Thank you. So, no, let me introduce Sheila first. So Sheila O'Keefe McCarthy is a friend and colleague, and she hails from Brock University. And I have been so fascinated with Sheila's work, her thesis work. I'm sure she has some artwork to share with us in some of her slides because it's moving. And so Sheila is going to present pain presentation in both male and female with acute coronary syndrome. And so it is my absolute pleasure to introduce my friend and colleague, Sheila O'Keefe McCarthy.
Thank you very much, Sue. I'm so honored and delighted to be able to be with all of you in this crazy distancing, but nursing is all about relationships and the ability to cultivate that. So we're doing it virtually, so congratulations to one and all. I'm pleased to present, as Emily had said, you know, getting into the gory details of research. I'm actually going to go into a little bit of the research in terms of a study that was conducted a couple of years ago with regards to the problematic situation around cardiac pain presentations that can often plague us as clinicians as we navigate a very, very busy unit ward and really trying to unearth what exactly those patients are actually feeling. Sue, you mentioned the art, which I do arts-based research, and this is not that presentation, so I send my apologies to you. But I can draw your attention to the actual pictures here, which is of this one and that one. These are thematic, poetic presentations of cardiac pain that were thematized and made into a theatrical photo exhibit and where it talks about raw pain. So in having said that, I'm just going to share with you to segue into us thinking about how they live through their pain. This is called Raw Pain. This is a thematized poem. Rising around you like a wave of cold heat, surprisingly unpredictable, unexpected, gripping talons of pain, ripping, digging in flesh, searing, piercing pain from inside out. I can't breathe. Am I dying? I'm dying. A sadistic volcano turned inward, erupting like acid, digging at you, gnawing away, stripping me raw, penetrating, incapacitating pain, exposed raw, vulnerable. This unrelenting pain, it's not going away, not getting any better. That was the voices of participants experiencing acute pain. It sets the stage for what I want to talk about, is the different pain presentations between men and women with acute coronary syndromes, and are we asking those questions, the appropriate questions that is linked to the meaning that they have about pain. This is a quantitative study that was conducted of 121 men and women. I have nothing to disclose. These are the team members that helped me get this through and completed. But cardiac pain, as you well know, when you're in your clinical practice, it's complex. The pain presentations are problematic for patients. It's hard to recognize for them and for clinicians to differentially diagnose as acute coronary syndrome. Sometimes our patients use, odd words like throbbing, pressing, sickening. They don't actually say pain. And sometimes they have an aching, deep kind of pain, whether or not it's an unstable angina episode or whether they're in an acute seminal heart attack. Now, as clinicians, we all know that with other types of pain, as with cardiac pain, it's a subjective, complex in nature, and it encompasses the sensory, discriminative, motivational, affective, cognitive, evaluative aspects. It's absolutely a layered experience. And it's very specific, as you know, to those individuals before us, with the components of, the spine, the brain, the cortex. The individual experience of cardiac pain is complicated, and it relates to the cumulative effect of not only the myocardial oxygen supply and demand and that imbalance, but the pain mechanisms underneath it and the neuromodulation of that painful stimuli at the level of the neural axis and the peripheral nerves and the spinal cord and the brain and etc. And the neuroplasticities and the changes that can take place because of acute and persistent pain, leading to central sensitization. So I want to share with you a little bit of my interest in understanding the acute coronary syndrome pain experience, because historically we have always used within practice to capture their pain intensity just using a one-dimensional pain numeric rating scale. I still use it in clinical today, of course I do, but lacking our cardiac pain assessments that employ that comprehensive evaluation of an emergent ACS-related episode. So this primary study wanted to initially look at the knowledge and attitudes that clinicians bring to the bedside and how it might impact cardiac pain intensity and state anxiety for our ACS patients, and then look at that the reciprocal relationship between cardiac pain and intensity and state anxiety to see if what it was in the literature, was it in clinical practice. But what I want to focus more so on this afternoon is this secondary sub-analysis, where we actually looked at the multi-dimensions of pain using a multi-dimensional pain tool to really uncover what these folks were presenting with. So we conducted a prospective descriptive relational repeated measure design of an emergency visit for ACS over an 8-hour period. We included acute coronary syndrome patients who were diagnosed with unstable angina and non-ST elevated myocardial infarction. We had to exclude the emergent patients because of the STEMI patients, because they were sent for angiogram and we wouldn't be able to do the repeated measures. We also wanted to look at acute pain and not perhaps the persistent cardiac pain after surgery, so we excluded those patients and those that were cognitively impaired. When I was doing data collection, I'm just going to focus on phase 2, where we had recruitment of 121 folks, where we took baseline demographics for general information, and then at the beginning of the research, we looked at the numeric rating scale cardiac pain intensity. We used the Spielberger State Trait Personality Inventory to tease out those that had a propensity for anxiety and those that we would be able to statistically control for that trait anxiety. So we get a real good look at what level of anxiety in the moment they had. And then the early warning prodromal symptoms I was always interested in as well. And then at 2, 4, 6, and 8 hours along that trajectory, we would again look at the numeric rating scale of what it was like 2 hours in the previous 2 hours, what was the most significant numeric rating scale, and then what they were experiencing now in the moment. And we also, at the 4-hour mark, we looked at the McGill Pain Questionnaire short form to get at that multidimensional aspect, and then looked at state anxiety as well. When we look at the study flow diagram of the patients that we included, we were able to have access to 191. Now, 70 of those were not really eligible, or I think it was about 29 of those didn't want to have anything to do with the research. 121 were consented, and we had about 5 lost to follow-up, which meant that they couldn't have a repeated measure, so they were excluded, and that was only about 4%. The acceptance rate for those enrolled was about 63%. You'll find it a wee bit interesting in regards to the sociodemographic characteristics of this sample. It is reflective of what we see in clinical practice. The mean age of this sample was 67 years. Men and women were equally represented, which I'm happy to report, and 66 were married. 60% reported that they were retired, and almost 1/3 of this sample had elementary school education. 60% were diagnosed with unstable angina, and 40% were diagnosed with non-ST elevated myocardial infarction. Of the 3 most comorbid reported comorbidities, 60% had hypertension, 25% had diabetes, and the other, and 60% also had hyperlipidemia. When we look at the trends in cardiac pain intensity over the actual 8-hour time frame, during follow-up cardiac pain for this group, The scores remained in the mild range from 1.1 to 2.4 across the board. And then when you look at the trends in pain management, where you've got nitroglycerin on the pink line and blue in terms of morphine equivalents, at baseline, I can tell you that the mean analgesic given was 3.2 milligrams of morphine equivalents. And then during follow-up, so those every 2 hours that we collected data, the mean analgesic administration ranged from 2.4 to 4 at any time frame. So obviously pain management was provided, and along with the nitroglycerin starting off at 917 to 1320 micrograms and ranged, adequate over the actual 8 hours. So we can see that obviously pain management practices were effective. When we look at actual trends in anxiety, this is an interesting slide because anxiety, if you recall, in this study was measured using the Spielberger State Trait Anxiety Inventory. It's a self-report measure that indicates, the level of intensity of feelings of anxiety in the moment. And it distinguishes between the propensity to have a personality trait disorder or anxiety disorder versus just what your anxiety is in the moment. So the possible SAI scores or anxiety scores would range perhaps between 20 and 80. According to the adult normative values, the value 33 would indicate, no, you're not anxious. 37 indicates that you might be, moderately anxious. And then 39 to 49 indicates that the individual is in a very anxious state. So if we look at the actual blue line of where our ACS participants were, you can see that this sample had persistent anxiety over the first 8 hours of an emergency admission, with the mean baseline anxiety being 45. During follow-up at all the time points, the anxiety scores ranged from 44 to 46 through the course of follow-up. So you can see clinically where this is extremely important. When you've got a myocardial muscle that is already stressed, it's ischemic, and then you have the increased anxiety on top of that. And when we talk about that in terms of preserving a threatened myocardial muscle, we need to, as clinicians, start to think in terms of how we are dealing not only with the pain, but also with anxiety as well, because increased anxiety certainly can cause increased tachycardia, hypertension, you increase the velocity of the blood flow. And if you've already got blood clot obviously blocking one of the arteries, you can have increased pain, and it's a vicious cycle. So something for us, definitely to think about. This is what I wanted to draw our attention to a little bit this afternoon. This table represents the frequencies of the sensory and affective descriptors that this sample used during the 4-hour mark of an 8-hour emergency acute coronary syndrome episode. Men and women in this study described a mixture of both neuropathic, so that's nerve-related damage, and chronic pain descriptors, and also acute nociceptive injury pain qualities early on in their actual trajectory of 4 hours, which is interesting because really I hadn't thought about just asking them, where's your pain level now? Is it at 4 or 8 or where is it? I never thought that I should have asked a little bit more in terms of a probing question, because if you can see here by the actual pink highlighted area, that the sensory descriptors included heavy, cramping, sharp, stabbing, and that's all acute pain descriptors. And we've heard that in clinical practice for sure. But also they talked about having it as a constant ache. It was very tender. It was throbbing, which basically combines both acute and chronic type of pain descriptors. And importantly as well, it really made me wake up in terms of they used an awful lot of neuropathic descriptors, which were gnawing, hot, burning, shooting, something that I was not perhaps as aware of as I should have been. If you look at the actual blue, it indicates the 20 to 30% of this actual sample, they related their pain with affective pain qualities, with fearful, sickening, punishing, cruel. And if you remember the actual poem that I recited, you can certainly hear that and feel that in the patient's words about talking about their pain. The McGill Pain Questionnaire offers us a global pain intensity ranking. And so 0 to 5, 0 is no pain, 1 is mild pain, 2 is discomforting, 3 is distressing, 4 horrible, and 5 excruciating, as it's indicated there. But what is of interest here, at the 4-hour mark, 66% of this sample describe their pain as discomforting and distressing, and this is comparable to an intensity level of moderate. So when we're thinking of a myocardial muscle that's already compromised and they're still at the moderate range in terms of how they're describing, it's very impactful in terms of, you know, our effective pain management practices, anti-anxiety lytics, all of those things to really bring down that numeric pain rating scale in a better range, you know, at least in the mild range, which it was, which I'll have a little bit more to say of why we found that as well. But also 26 reported that their pain was horrible at 4 hours, excruciating at 4 hours, and that corresponds obviously to a very severe pain level of intensity. So something, again, for us to think about, are we asking those questions that are important to the patient in terms of how they perceive their pain? We were able to understand that our patient along the 8 hours had mild pain. We know from the actual graphs shown that pain management was pristine, that it was effective. I'm very happy to report that. But I want us to try and think a little bit deeper in terms of perhaps why we resulted in the mild pain intensity scores. And I immediately always go, you know, to the science as well. So talking about the pathophysiology of a white clot versus a red clot in terms of the type of ACS that the patients experienced. A white clot, as you know, typically is related to unstable angina and non-ST elevated myocardial infarctions. And they develop rich white clots in areas of high shear and stress. And it only partially occludes the coronary artery. And it involves multiple areas of blockage and necrosis, and perhaps not all at the same time. So perhaps that might be one of the reasons why I observed mild pain across those 8 hours. And if you recall, the sample was predominantly unstable angina and non-ST elevated myocardial infarction. It's also a lot of interest to me in terms of, you know, there's little data out there to distinguish between whether or not a first-time ACS occurrence versus a repeated cardiac episode or insult. It doesn't increase, you know, in terms of the myocardial scar tissue from past ischemic injury, insult, and death, and does it result in less or greater pain perception? I mean, we need to know that. Is it more, you know, more nociceptive in acute, or is it more neuropathic? So certainly another area for investigation. Or perhaps, does more scar tissue prevent transmission of that noxious input, thereby, you know, altering the pain perception? Does it cause maladaptation and change in the plasticity that we're not aware of? And so that's why we're not expecting perhaps neuropathic pain qualities along an acute episode that we wouldn't know to ask about. McGill et al. In 2012 conducted a similar study in ACS where he looked at persistent forms of pain post-PCI and found that at 3 and 6 months that most of his participants described an admixture of nociceptive and neuropathic pain. So we're finding the same thing. And it's very important for us to think about that perhaps, you know, ACS starting off with the first event and then multiple repetitive events, we're getting into perhaps a persistent chronic on top of an acute episode that we need to be able to evaluate. Comorbidity obviously might have an impact on whether we found mild pain scores, because when we look at our ACS sample, we had 30% were diabetic, 60% were hypertensive. We know that those that have a hypertensive genetic phenotype have maladaptive processes, or could have, that impact pain perception, that they become hypoalgesia, in which their pain perception is blunted, and maybe that's why we had a mild pain in this actual sample. And then, of course, we know well the detrimental effects of diabetes and neuropathy that could develop, and you have decreased pain perception as well. So just some things for us to think about in terms of how our patients are presenting and perhaps why they're presenting in a certain way regarding their pain. So there's a few things to think about in terms of, you know, our next steps. Certainly this was not, you know, a comprehensive study, but I think that it warrants further investigation because of the findings. I would really love to do a larger multi-site full examination of ACS in regards to unstable angina, non-ST elevated myocardial infarction, the STEMI, and then do gender analysis, and then doing stratification with regards to first time versus repetitive event, and to be able to really tease out the kind of pain presentations, doing a nice gender analysis, and then getting the differentiation determined by echocardiography to really be able to see, you know, what the motion and wall motion is, to see what the actual diagnosis is, all of those types of things. And then to be able to perhaps do a study where you look at the comorbidities and risk factor profile and paying attention to those that are diabetic and hypertension, and see what different pain presentations or different qualifiers they use to see if we can really capture what's going on in their pain presentation. So we know that 66% of this sample had both nociceptive and neuropathic descriptor characteristics of cardiac pain that perhaps we might not have been as aware of. And I think it's important for us to think about not only just using the normal numeric rating scale, but maybe a comprehensive multi-dimensional tool would be a bit more appropriate in terms of our level of evaluation and question probing. We don't really know as to whether or not, you know, the individual pain perceptions are, as I've said, due to pathophysiology, the occurrence of first versus repetitive ACS episode, comorbidities, or that equivocal relationship where, you know, anginal pain versus no ischemic substrate, and then you can have myocardial ischemia and no pain. So, and is that related to, you know, maladaptation or a problem with plasticity? So just some things for us to think about. But I think it's important in the take home is that pain arising from ACS, it requires us to really understand exactly what's underneath it all. So the ischemic metabolic, the neuropathophysiology mechanisms that contribute to the individual patient pain presentation, because it is always variable and it always kind of keeps us on our toes as to how we should really comprehensively assess that. So I want to thank you for your kind attention and the participants in this study, the sources of my funding as well, and welcome any and all questions. Thanks so very much.
Wonderful. Thank you, Sheila. Thank you very much. And so we have a little bit of time here to entertain a couple of questions. If anybody would like to type into the chat box, that would be wonderful. And Sheila, sometimes it's interesting when you think, you know, as a young new nurse, the only thing you ever thought influenced pain was past history. You know, what have you been subjected to in the past? And it just is so much more complex than that.
It is, and I think I didn't realize it as a new nurse. Certainly, I was very much, you know, went from my novice reality of task-oriented, and then I increased my knowledge and skills and acumen. But it was the patients that drove me to really want to understand their pain experience, because I really felt that as nurses, we initially weren't as adept to be able to get into individuate our pain assessments for our folks. And so really listening to what they're saying, what they're not saying, are we asking the right questions? I do use the McGill pain short form along with the numeric rating scale as well. I also monitor anxiety because of that co-reciprocal relationship, and it's very important to me to stave off cardiovascular morbidity and mortality by being that effective intervention, as we all are, cardiovascular nurses, in the way in which we evaluate. And then asking them what their pain means to them. And Emily brought up a great point. saying, they don't want to talk about it, but really a lot of people talk about, I don't think I'll ever be sexual again because, I can't be active because I'm going to have pain, and they're frightened, and they just need that ability to advocate for themselves and to be able to have that education that really is very important. So nurses educate. We are the conduit of all of that. That is important in patient care in all avenues. And pain is so much along the trajectory of cardiovascular disease from, start to finish. We can't dismiss that at all.
No. Now, I think we have time for one question. We'll just cut the networking session a little bit short next, but Brenda Ridley says, what are some options for longer term pain management with ACS and ongoing pain?
Yes, thank you very much. And that is a persistent problem. I have worked with Dr. Michael McGillion with refractory angina, where there are guidelines for that, 2012. And there are various different modalities for persistent forms of cardiac pain, from using TENS to acupuncture to laser treatment to medications as well, to cognitive behavioral therapy. It is a multimodal approach to pain that is persistent and retractable. It's quite a problem clinically, and we're finding that more. And I'm thinking that this little study that I shared with you speaks to that I think we're dealing more with a persistent pain, that anti-inflammatory endothelial chronic dysfunction that starts the sequelae, and the acute injury is, acute on chronic. And I think we really kind of might need to get that into our awareness in terms of how we start to approach, management, and then helping them to co-facilitate their management.
Yes, absolutely. Well, thank you. Thank you very much. Very interesting work, Sheila. I follow your work. It's fascinating, and I really appreciate it, as I'm sure our audience has.
Thank you so much. Appreciate that.
Okay, so now might be a great time if you want to stand up, kind of stretch out, and I will share with you my screen. And so in the section of Cooking with Sue, if you had to endure that,